Hi, listeners. My name is Professor Sunday Olajide Awofisayo. I am the principal researcher at Bioscientific Research Group, Department of Clinical Pharmacy and Biopharmacy, University of Uyo. Today, I'll be making a brief talk on medication errors, and I'm looking at the definition of medication errors, types of medication errors, global impact of medication errors, and I'll also be looking at some case studies just to drive the nail into the wood. And so the learning objective for this study include defining medication error, differentiating between medication error, adverse drug reaction, and adverse drug effects. We use all these terms, but it will be okay for us to know when each comes into play. They want to classify medication error according to their occurrence within the medication use process. We like to also analyze the root causes of medication errors using contemporary theoretical models. We want to evaluate global epidemiology and economic burdens of medication errors. We would also like to critically assess the landmark medication error cases. We will propose evidence-based interventions for reducing medication errors. And finally, we will design research frameworks for studying medication errors in healthcare systems. So, by way of introduction, medication error represents one of the most significant threats to patient safety worldwide. Medication error happens everywhere and is a threat. So, going to the hospital, let us just believe that the person will not have an encounter with one. Okay, so modern healthcare environment has become increasingly complex because there's polypharmacy. Most prescriptions will feature 5, 6, 7, 8 drugs because of course, the complaints that the patient brought to the consulting room. Then we have advanced therapeutics. Things have really gone very advanced. So different drugs, different delivery pattern and all of that. And so whoever is managing or handling these drugs should know how that drug works, not just diclofenac. Is it sustained release tablet? Is it a control release? Is it a model? All those kind of whatever. We need to know what kind of drug we have. Carbamazepine, a control release, and a conventional release. The way they relate in the patient's body is not the same. And then we have multiple healthcare providers. Most persons don't have one prescriber, or they don't have one healthcare person attending to them. The fellow who is taking drug from you in your community pharmacy today has probably visited another person 2 days ago. And if it's not that literate, the diclofenac you're about to give of this brand, this fellow has also received the same from another person somewhere. And you can just bet it. He's going to go and take the two of them together. And when there's an issue, have you seen where everything? So we have an electronic prescribing system. And that too has its own attendant. Then the aging population, we have more older people. And the challenges they also bring to the healthcare system. And then there's increased chronic disease burden, tension, cancer, so many of them all over the place. So definition. National Coordinating Council for Medication Error Reporting and Prevention defines medication error as any preventable event that may cause or lead to inappropriate medication use or patient harm while the medication is in the control of the healthcare professional. That could be the pharmacist or the nurse or the physician and, of course, the patient. So other drug events are injuries resulting from medication use. Other drug events are injuries resulting from the use of medication. For example, hypoglycemia from using insulin. That's an event. That fellow took insulin and had hypoglycemia. That's a other drug event. We didn't want to give that insulin so that the blood sugar goes too low. Bleeding from warfarin. We don't want to give warfarin so that the bleeding from the nose or the mouth or the anus start happening. That drug reaction, a harmful and unintended response occurring at normal doses. As for other drug events, it may be because there's a medication error. It could also be because there was no medication error. It just happened. But when we say adverse drug reaction, it's not medication error related. Normal dose, yet look at what we're seeing here. There's a problem. So all adverse drug reactions are adverse drug events, but not all adverse drug events are adverse drug reactions. Medication error is an adverse drug event, but we don't term it adverse drug reaction. I hope I'm able to differentiate that. Global epidemiology. WHO estimates that millions of medication errors happen every year. Medication-related harm cost billions of dollars across the globe. And these are monies that we can actually bring in, because medication errors are actually preventable. So that means those billions of dollars can actually be saved, but they slip off our fingers. Those billions of dollars could have been deployed to some developmental, even in Nigeria, as we're a developing country, billions of naira are still going that way. Maybe to re-hospitalize someone or to salvage it's a waste. Medication error have actually led to some very serious problems beyond what I've just tried to describe. So common contributing factors include workforce shortages in all our facilities. We don't have enough physicians, we don't have enough nurses, we don't have enough pharmacists, not enough laboratory scientists. And look at the burden of work, and then you can see where the system is failing. And then we have limited technology. If only we have deployed technology into what we're doing, we'd have been able to at least cope up a little, but these are not there. And then we don't have an adequate reporting system. If there was a very serious medication error in hospital A, and then it was reported, it can also help save the situation from replicating itself in another setting. But it happens there, it's happening there, yeah, and then nobody's even, and so we don't even know anything is happening. And that's unfortunate. And then we have a very weak regulatory framework that can help ensure that people's lives are saved and that these medication errors don't even happen at all. And now we need to know that there are some vulnerable groups that attend our hospitals. Vulnerable in terms of their situation, vulnerable in terms of what medication errors can do to them. Example, children, neonates, infants, elderly, pregnant women, critically ill patients. All of these persons have been impacted by medication errors. And a lot of things have happened to them. If you ask your neighbors around you, some of them have one or two gory stories to tell. They want to, oh, it was that pharmacy that did this, did that, it was that hospital, that doctor, that is and that. And some cannot even forget in a hurry. So medication errors in these populations often have more severe consequences due to altered physiology or complex treatment regimen that they take. Let's look at the historical evolution of medication error research. In our group, Bioscird Research Group of Department of Clinical Pharmacy and Biopharmacy, we are actually looking at medication error in this third quarter of 2026. And every Friday when we meet, we have a topic to look at, and after that we discuss it extensively, and then we decide on what research we want to do to gather data so that we can actually be able to relate to policymakers on the way forward. Because if nobody is doing research in this area, then we're going to be living life as usual. So there was a publication in 1999, and that publication estimated that 44,000 to 90,000 preventable deaths happen annually in the US. 44,000 to 90,000, almost 100,000 deaths happen in US, despite the technological status of that climb. Then what do you think happens in our home here, where we don't even have records? In 2004, WHO established a World Alliance for Patient Safety, and that launched a global initiative to reduce preventable harm from the use of medications. In 2017, Relentlessly, WHO also launched medication without harm, and it was launched as the third WHO Global Patient Safety Challenge. The program in 2004 and 2017 were actually targeted to reduce severe avoidable medication-related harm by 50%. If that happens, great. Maybe with time, further reduction till it becomes almost non-existent. So let's talk about medication use process, from the prescribing to transcribing of that prescription, to dispensing, and then to administering the medications and monitoring. These 5 cardinal positions, just like a set of cards or sliced cheese, are where medication errors can actually pop its ugly head. And it could happen in any of the stages, or even multiple positions on that stage. So NCCMERP, that is National Coordinating Council for Medication Error Reporting and Prevention, actually gives a classification for kind of errors that we can have in our clinical settings. And the errors are categorized as A, B, C, D, E, F, G, H, I, where A is circumstances with capacity for error, and I is death. H is life-sustaining intervention required. There's some medication errors that consequent to it, a life-sustaining intervention is required, otherwise the person will die. But there are some other medication errors that the person dies almost instantly. There are some, like category G, a permanent harm has been done due to medication error. It's not reversible. So it will be okay for us to ensure that we block the incident of medication error. I'd like to give an illustration. If water spills on your tile in your house, don't even wait till later to mop it and clean it. Before you know it, somebody has slipped and broken his head. Are you going to bring money from that your account to hospitalize the person? Can you just get a picture of what we're talking about here? So medication error can be prevented. It's a preventable event. And if the system is right, then it can be brought to the minimum. There are some drugs that we call high alert medications. Once they feature on the prescription as a pharmacist, even the prescriber as a physician, once you think you are going to need this drug, don't just write the drug and think you've done your own. Don't just dispense the drug as a pharmacist, think, oh, I've already, or maybe you've cancelled. You need to follow, because that drug in that person's hand is a high alert medication. Example of some medications are insulin, warfarin, and some other similar drugs. So there's some concentrated electrolyte like potassium chloride, the opioids like morphine, fentanyl, antiarrhythmics like amiodarone, lidocaine, sedatives like propofol and midazolam, magnesium sulfate that is used in obstetrics. So don't just prescribe and think I'm done and they know what to do. If you are painstaking, having known that somebody is taking magnesium sulfate and you pay more attention, you can save the life of that person than to be sorry. It is good to be safe than to be sorry. So there's some look-alike and sound-alike drugs. We call them Lassa drugs: dopamine and dobutamine, prednisolone and prednisone, vinblastine and vincristine, lamictal and lamisil. You see, one can give one for the other, and that is still premised on medication error. There's some theoretical models of medication error. The Swiss cheese model that tells us that hazard can happen in any of the layers till the patient is harmed, and so we can block it from any of the points if we pay attention, if our system pays attention to those different levels. We are more able to block it before it matures, so to say. So we also look at the human factor theory. Humans are involved and humans are liable to mistakes, more so when we have cognitive overhead, fatigue, environmental distractions, poor interface design. And so if you're going to consult with a client, you must do that in a very quiet environment. Not where there's music going on there and your son or daughter or your staff or somebody is making noise somewhere. One can easily make mistakes when those things happen like that. And so just last week, we were looking at medication error in the light of human factors and system failures. If you can pay attention to these two, then we will have slashed medication error incidents by more than 50%. In any setting, whether in a community pharmacy setting or in the hospital, if we pay attention to human factors and system failure, if we can put our system right, how drugs are prescribed, how they are checked, how they are handed over to the clients, now that the client has taken them home, how we follow up till the patient comes back again, then we will reduce medication error by more than 50%. For global impacts, it could be direct costs impinging on you having to use additional medication because of a problem that was caused by medication error, intensive care admission with all the attendant cost that goes with it, additional diagnostic tests, emergency interventions, litigation and compensation claims. All of this cumulatively forms what we talk about when we say medication error has huge financial impact. We have the direct costs, loss of productivity, long-term disability, caregiver burden, reduced workforce participation. And so WHO estimates that medication error costs billions of dollars annually and consumes significant healthcare resources that could otherwise have been directed towards improving patient care. How about intangible costs? Psychological trauma, loss of trust in the healthcare system, and that's what we live with in most of our countries in the developing world. So let's look at one or two cases. Vincristine intrathecal injection. Vincristine should only be administered intravenously. But imagine the same drug given intrathecally. That leads to paralysis instantly or death. When the packaging of a drug resembles another, and then one can take one for. And so the lesson we learn from that is that we have to have adequate check before we administer medications. A heparin overdose, a case of a neonatal intensive care unit drama, reported a heparin overdose due to concentration mix-up. This concentration was given instead of that, and the neonate had severe bleeding, and then maybe sometimes that leads to death. And so we should have independent double checking in our system. The system should make provision for independent double checking. What this person didn't see, that other person might see it before the harm is done. The methotrexate daily dosing error. Methotrexate is ideally a weekly administration regime, and somebody has started giving it, a new staff has started giving it daily, and then that leads to some fatalities: pancytopenia, mucocytosis, death. And poor prescription review. If our prescriptions are also reviewed, somebody can spot the error. The better to 10-fold dosing error. 1 milligram, sometimes you have somebody writing as 10 milligram, and the person who's dispensing or administering is just following hook, line, and sinker without checking and saying, should it be 1 or 10? Sorry. I was going to write 1. I'm sorry, I didn't know. Medication error. Human factors. Developing countries. We'd like to gradually wind up this lecture by describing the scenario in developing countries. In developing countries, we still have the mentality of writing prescriptions illegibly for whatever reasons in this present time, and writing handwritten prescriptions with illegible fonts. The inadequate pharmacy staffing. If indeed our system recognizes that pharmacists are responsible for therapeutic outcomes, then they're going to employ more pharmacists. We have most of our clinics, even big hospitals, severely short-staffed of pharmacy staff. And that's just because it appears the understanding is not there. And so if we do researches and push it forward, and the CMDs get to see this, and they reason it out, or maybe that's what we're saying, they reason it out, things can change. But if we don't do any research and we don't have any data to put forward, then no. That means we're just as good, we're cool, we're fine. Pharmacovigilance, limited electronic health records, all of these are instrumental to the increase in medication error events that we have steadily. How do we prevent medication errors? Technology can help us. Computerized physician order entry, barcode medication administration with the computer barcodes and the scanner. We can know that no, this is not the right. Because just pick it thinking that you pick the right one. But if the SOP is that you must scan it before you use, thank God. That's when you even know how important the barcode thing is. So, distinguished ladies and gentlemen, this month we are actually looking at medication error from different perspectives, and we're already doing publications. We are doing researches. We have surveys here and there. By the end of the month, I guess you want to follow us and see which of the publications will interest you, and we are stopping at nothing to push it to where all these efforts count. Thank you very much.